Welcome to the Mental Health Bootcamp Podcast. This is the podcast where 5 psychotherapists, 3 of us Canadian and 2 of us American, serve you cutting-edge mental health knowledge. I am Dr. Ryan Howes, a clinical psychologist from Pasadena, California.
And I am Dr. Brooke Lewis, a registered clinical counselor from the Greater Vancouver area.
And I'm Joanna Boyd, also a registered clinical counselor from the Greater Vancouver area.
I'm Chris Boyd, a psychotherapist from Coquitlam.
And I'm Daniela, and I'm a psychotherapist from Los Angeles, California.
Welcome. What a wonderful, wonderful surprise. And I have to say, I feel a little, I feel a little better having 2 Americans here today. It's kind of nice. All this Canadian energy, it's overwhelmingly polite and positive, and I'm glad to have another.
I'm glad to be here with you.
Ryan's been outnumbered for so long.
We're still outnumbered.
Yeah,
we are, but it's growing. Who knows?
It's up in the right direction. Yeah,
get up to 50-50 at some point. We're really happy to have Daniela here tonight because this is our book club meeting, and we're going to be talking about how the mind-body connection and how pain and the brain work together. So this is really fun to have a special guest.
for sure. Yeah, so Daniela, actually, she has a master's in social work from University of Southern California, USC. She's a director of content at the Pain Psychology Center in Los Angeles. She trains all new clinicians in pain reprocessing therapy and demonstrates a holistic and actionable approach to overcoming chronic pain.
Thank you for reading the blurb from the website. I appreciate it.
I made a few changes. I took a few things out, rearranged a few words.
No, I appreciate it. I started working at the Pain Psychology Center, treating patients. And I got pretty close to Alan Gordon, who wrote The Way Out. And he kind of asked me to become the director of content at the Pain Reprocessing Therapy Center. And so we actually co-founded it together. And now I am training all of the people who come through the center. And I think we're training about 100 to 200 people almost every other month at this point. So it's really exciting. And, our focus and our mission is really to change the way that chronic pain is treated worldwide. And, we're doing this slowly, but also kind of quickly since we only opened up about 6 months ago.
Whoa.
Mm-hmm.
That's wild.
Yeah, it really is.
But I guess that just also goes to show just how important that topic is, chronic pain, and how many people suffer with it, and how it shows up in clinical practice. And so that's great. Wow.
Yeah. I mean, there are 40 to 50 million people in the US, and I know maybe you Canadians don't care about that. No, I'm just joking, but 40 to 50 million Americans suffer from chronic pain, and I believe it's 1.2 billion worldwide. So it's a very serious problem.
Yeah, I think it's safe to say that Canadians are always worried about the Americans. Yeah, our neighbors to the south, so including the chronic pain. But that's amazing. So how big is your team then at the clinic in Los Angeles?
So at the clinic, the Pain Psychology Center, there's about 50 clinicians. But at the Pain Reprocessing Therapy Center, it's just me, Alan, one other person, and a couple of other trainers. So it's still pretty new and pretty small, but going fast.
Yeah, no kidding.
Wow.
Mm-hmm.
It's amazing. That's amazing. Well, great. Let's get started here. What do you say?
Should we pause for our jingle?
Yes, Daniela, we actually have a jingle that we kind of insert here of Joanna singing our book club song. So we'll just pause for just a moment to add the jingle. And here we go. And there it was. Wow, what a song, Joe. My goodness.
Yeah.
Oh, it's going to be a real treat for you, Daniela, when you listen back.
I'm so excited.
It is quite a treat, no doubt about it. So we all read The Way Out, and and learned a bit about pain reprocessing therapy. And I'm just, I guess our readers maybe have read along as well. Hope so. Some of our listeners have read along. But we should probably, as we usually do, we kind of define our terms and start off by just talking about what is this topic about? And we have an expert here with us. So Daniela, what is pain reprocessing therapy?
So pain reprocessing therapy is the first evidence-based practice or modality of therapy that is proven to work to treat chronic pain, and not just pain management, but the treatment of chronic pain. And pain reprocessing therapy is kind of just a system of techniques to turn off the learned neural circuits in the brain that are misfiring that there is something wrong in the body when actually there isn't.
Okay. Now,
Yeah.
now, when we're talking about chronic pain, some people may be unfamiliar with that, or they've heard it, but they're not really sure what it is that we're talking about regarding chronic pain. Is this tennis elbow that we're talking about? Is this fibromyalgia? Is this what are we talking about with chronic pain?
I mean, yeah, well, that it definitely can include all of those things: fibromyalgia, migraines, IBS, back pain, neck pain, joint pain, all of that. But, sometimes it starts off with an injury, and it's acute pain that turns into chronic pain, or it just kind of like randomly crops up on its own. And then, recent studies have shown that chronic back pain and neck pain and fibromyalgia and all these other symptoms are more likely to be rooted in psychological or neurobiological issues rather than in structural or physical problems in the body.
Now, this is where we get to the area that's maybe the touchiest area of this, right? Which is where people may hear some of the words you're saying and think, wait a minute, are you saying this is all in my head? Are you saying I'm just making this up, or I just got to think my way out of this? And I know that that's a big topic in the book. So maybe you could share a little bit about that.
Yeah, I mean, absolutely not. All pain is real pain. And, all pain, regardless of whether it's rooted in a structural problem or not, is generated in the brain. So although the pain can be addressed psychologically, it does not imply that the pain is imaginary or that it's kind of made up. It feels the same whether it's rooted in something structural or not.
Yeah, well said. So then the mechanism for helping people identify, and I know a big portion of the book is about, okay, is this something that is neuroplastic pain, or is this something that is an actual structural, a component of pain that actually has a structural basis? I know there's a bit of a craft to try to determine between the two.
Yeah, I mean, there's actually an appendix at the back of the book that I think it's about 12 criteria. And as I practice, I've gotten much better. Usually within the first few minutes of a session, I can tell whether this is neuroplastic or not. Obviously, there are cases where I'm unsure. And if I am unsure, I do refer to a physician, because it's out of the scope of my practice to try to treat someone who has a structural or physical problem with talk therapy. That would be really unethical. But I have gotten pretty good at diagnosing on my own just from doing this multiple times.
Yeah, that's a really good point, because often we need to connect with clients and ensure that they're getting the medical support that they need. And I know the appendix actually talks about that. Is there any medical diagnosis or anything that's been found from a medical perspective in terms of what's causing the pain, right? What other kind? I'm so curious. Within minutes of talking to clients, what kind of things do you look for the most? Because there's a lot of things on that appendix.
Absolutely. I mean, a lot of times I'll hear that they have multiple symptoms. And if I hear that, if they have, head pain and back pain and IBS, it's like that's almost an automatic sign pointing to neuroplastic pain, because the likelihood of someone suffering from all of these different symptoms and it all being chronic pain that's rooted in physical damage is really rare, because chronic pain rooted in structural damage is pretty rare in and of itself. So to have multiple symptoms, it makes it super unlikely. So that's one of the biggest tell-all signs. Another one is if they have a history of anxiety or a history of depression, or any kind of adverse childhood experiences. That's a really big sign.
Yeah, one of the examples in the book is of someone who comes in with chronic pain of both wrists, and this idea of this happening on both sides of the body would be rare to have a real structural basis to it. Two different
Absolutely
sides of your or ends of your appendage. There, it's difficult for that to happen. So that's a lot of different these signs that are really interesting.
Yeah, or sometimes I'll ask my patients if they have family members who have different chronic pain symptoms, and if their parent had back pain or other symptoms, just the mere fact that they have this awareness around there can be these type of pain symptoms, it'll kind of arise just because it's so familiar to them, like they've grown up with it. And so the moment that they feel some twinge in their back, like, oh my God, this must be the same pain that my mom has endured for, decades.
Yes. Have any of us regular podcasters here, have any of you guys experienced any of this sort of chronic pain issue that you are aware of?
I wouldn't, obviously lots of pain, but I wouldn't say it's ever been chronic. So it might be lower back pain or something like that. But usually within a few days, the intensity of it improves, right?
Yeah.
So I'm very fortunate. I haven't dealt with a lot of chronic pain, no.
Yeah,
But no, tons of people that have, though, of course.
certainly.
Why this book was so compelling, right?
Sure.
It's interesting because I just had a conversation with Dave Clark. He gave a speech to the Whole Pain Psychology Center about an hour ago, and he was talking about, well, what is it that makes someone more susceptible to having chronic pain, or from an acute injury to kind of developing into chronic pain? What is the difference between people that one will get this and other people won't? And so really kind of went back to all the criteria of adverse childhood experiences, and there are different traits and there are different triggers, or there are different kind of negative emotional patterns that these people kind of gravitate towards. And because of that, that's why they'll have these pain symptoms. And that's kind of the commonality that I'll see between people who do develop chronic pain.
Yeah. What resonated with me too is that the negative self-talk, right? So, from a CBT perspective, we talk about cognitive distortions. So a lot of critical thinking and whatnot. Seem to be a bit of a trait, but trauma, keeps on popping up within the clinical setting, right?
Yeah, we talk about trauma a lot on this podcast, probably because some of us enjoy talking about trauma. But yeah, no, I think you make some really good points about that, right? Like, so just the adverse childhood experiences, but also the witnessing or the normalizing within a family unit and how that kind of gets passed on. And then when you're looking at that, well, then if that's the family environment that you're growing with, what protective factors are you then establishing? If you're witnessing, like, the person who is there to teach you those protective factors maybe doesn't know them themselves, right? And then here we go. Now we just have some intergenerational aspects to this. So yeah, very, very interesting. Something in my own client base that I've noticed is there seems to be some sort of tendencies culturally as well as a big indicator, and whether that is, or whether or not that has something to do with the adverse childhood experiences or traumas from those cultures. So what generation are they? Canadian? What if they've immigrated here first or second generation, and if they've immigrated here, the trauma from where they came from, like what actually contributed to them coming here, sometimes can play a part, or at least that's what I've noticed.
Yeah,
Sure.
Well, I ask you guys because I about every 6 months have a nice lower back pain issue. So as I was reading the book, I was becoming very aware of, okay, what, how might this relate to this treatment and diagnosis? And I think there's a lot to be said for that. I'm sure lower back pain is something you encounter quite a bit, Daniela.
Oh yeah, it's the most popular one actually
Oh, good.
that I see.
Oh,
So you can be cured.
I believe it. I believe it. So getting a little bit into the treatment of this is very interesting, very fascinating as well, because there's a lot of mindfulness that goes along with this, at least in the initial stages, right?
Mm-hmm.
So tell us how to apply mindfulness and pain, because a lot of people would say, "Gosh, I don't want to look at my pain. I don't want to sit with that. That seems really uncomfortable." So what do we do there?
Absolutely. So, I mean, there's two different ways that we kind of treat this. Number one is there's the psychoeducation piece where we, teach people like, okay, what is going on in your body? And sometimes once we tell them what is going on from like a neurobiological perspective, their pain goes away because they're like, oh, I know what it is. And that kind of like dissipates the fear. But sometimes we need to do two things, right? One thing is educating them about what's going on and then showing them that, they're actually safe and that their body is okay. And so we use mindfulness to kind of like look into the body, right? And expose them to the thing that they're scared of, which is the pain, but in a safe way. And so if they can do that and attend to their, physical sensations or this physical pain from a curious and objective way, then that'll kind of turn off the fear. And then they'll kind of get this corrective experience where it's like, oh, well, if my pain turned off now, that means that I have the capacity to turn it off all the time. And that means that there's nothing that's physically wrong with me, right? Because they get this evidence. If they had a broken foot and they were kind of like walking on, there wouldn't be a moment when they're walking that they wouldn't feel the pain, right? The pain is there to protect us from causing more tissue damage. And so if just through the use of mindfulness, their pain goes away, they get that evidence that there is nothing wrong with their body and that their body is safe. And so that's how the mindfulness piece is used.
Great.
And you noted, Daniela, like around safety, or in the book at least, if someone doesn't feel safe, would you say that you can build up that safe? Like it's okay if you can only be mindful for even a matter of seconds. I think Alan Gordon noted it could, a patient was just like 1 or 2 seconds able to think of the pain, then they had to stop. And so does that help someone build safety? Is just taking your time with it? Or is there anything else that you can do to build the safety around approaching or facing that pain or noticing it, I guess?
Yes, I mean, you can start really slow, but there are also other tools that you can use to get rid of the pain. If, the level of fear around the pain is too high, we'll do other types of mindfulness exercises like leaning into positive sensations. And, it's if you think about someone who gets into like a car accident and they're driving for the first time, they're not going to like get on a highway, but they're going to start in a parking lot. And so that's kind of what's going on with leaning into positive sensations. It's we want to get them comfortable with a more neutral thing like that parking lot with those neutral sensations. And once they can become comfortable with that, maybe they can start looking into those more painful sensations and being exposed to those things or exposed to that, highway, so to say, right?
Okay.
I was catching myself kind of halfway wishing I was experiencing one of those lower back issues while I was reading the book. So I was like, oh, I'd love to practice this right now.
That would have been like a paradoxical intervention though, wouldn't it? Like you want to experience the pain and then the pain actually subsides.
maybe. But I could definitely relate to the fear. And I know that the fear of the pain is a major component of this treatment overall. And I could definitely relate to those times when I have this week or two of lower back pain, and I wake up in the morning and I like remember, oh, I've got this back thing, and oh, I'm gonna really feel it's gonna hurt so bad to get out of bed, and I know I'm just setting myself up for that very cycle of fearing the pain and then experiencing it and probably exacerbating the pain as a result, right?
Absolutely. And fear can be kind of an interesting word because some of my clients will be like, oh, well, I'm not really afraid of the pain. But then I'll ask them, well, are you frustrated? Does it make you annoyed? Like, what are kind of the adjectives that you would put to it? And if those words are things that would put your brain on high alert or make your brain feel unsafe, then, that falls under the umbrella of fear. So if you're frustrated, that your day is going to be ruined, right? That does fall under the umbrella of fear. Maybe you're not scared of the symptoms themselves, but you're scared about what the consequences are going to be if the pain does, come on.
Mhm.
For sure. I guess that kind of coincides with the mindfulness practice as well, because you're trying to notice the fear, right? Or I think in the book they call it kind of catching the fears. So
Mm-hmm.
those sensations or feelings or beliefs that pop into your mind, right?
Yeah. And something that I use with my clients is I call it the 3 C's. And I think another clinician at the Pain Psychology Center came up with it. I think her name is Erica. She calls it the 3 C's, which is catch, congratulate, and carry on. So it's catch the negative thought or catch the fear, congratulate yourself for noticing it, and then kind of carry on, usually using some type of mindfulness technique or doing something that you enjoy, right? A lot of chronic pain patients, they're kind of stricken of all joy in their lives. And it can be really, really dark. And so if we can help them find pockets of joy in their life and really like lean into that, it can be like the first way out of this really dark place.
That's great.
And you noted as well, which I think is helpful, is that if the pain is too high to even do the somatic tracking or mindfulness, it's just do the avoidance behaviors, which the book talks about how in some cases the avoiding actually can be helpful, just to go that way. And then when the pain is at a low amount or just beginning, that's the best time to kind of practice that, noticing the somatic tracking. So it's just, I like the positive spin on avoidance behaviors, I guess.
Absolutely.
Yeah.
Especially with this clientele. It's pain patients are usually part of their, I was talking about traits, part of the characteristic traits are being really perfectionistic, being really type A, really want to, problem solving. And so when you say you have permission to use these avoidance behaviors, and not only permission, but it's actually the best thing that you can do in those moments where the fear is too high, then that makes them feel like, oh, okay, I have a plan. And like, I know that might be feeding into this perfectionistic attitude, but like at the same time, you can't rip away that safety net when they're not ready. So I think the avoidance behaviors are really important.
And I guess, can we give a few examples of those? Like, I guess, like, if you're sitting down and your pain flares up, you can stand up so you can kind of avoid that sitting position. Like, could you give some other examples just for listeners as to what some avoidance behaviors could be given certain pains?
Yeah, I actually had a client who had really bad headaches, and the only time that his headaches went away were when he was either drinking water or chewing gum. So that was kind of his avoidance behavior. Sometimes I'll use these avoidance behaviors as, by my, like when I'm doing a somatic tracking exercise, for example, and it's like the pain is getting too high and I notice that the level of fear is too high, I'll say, you know what, let's just go to the breath. And so the breath will be the avoidance behavior mid somatic tracking exercise. And somatic tracking is this mindfulness, using mindfulness to kind of track the pain, just for anyone who doesn't know what that is or didn't read the book.
It's an awareness. You're being in a mindfulness sort of way, non-judgmental. You're not trying to change anything. You're just being aware of what the pain is doing, where it is in your body, that sort of thing, right?
Isn't kind of describing it too, like the size of it or the sharpness of it, like, and I liked Alan's usage of comedy. I think it seems like he has a rich history of comedy there, humor in his life, but that kind of shown through a bit too in the book as well, that he tries to see it in more of a I don't want to minimize it here, but he tries to use metaphors or analogies that would be a little more lighthearted, right?
No, that is exactly what it is. We kind of divided it to 3 components. So somatic tracking is mindfulness, safety reappraisal, and positive affect induction. And positive affect induction is actually just like a fancy way of saying like, be funny, lighten the mood. Because when patients are usually looking at their pain, they're kind of locked onto it. And it's something that Alan calls like hawk mode, because they're kind of glaring at it like a, predator or maybe the prey actually that's like looking for the predator. And so the way to kind of get someone to not be locked on is to actually inject a little bit of lightness or a little bit of joy. As I was saying before, they kind of like lack that ability to let go and have joy. And that kind of ties back to like adverse childhood experiences, right? There's some of my patients who weren't really able to play as children, right? And so then as adults, they don't have that playfulness. And so part of our work together is injecting that playfulness into their lives, and also maybe even with their pain, right? So we're looking at the pain, but we're thinking about something silly, right? Or we're kind of describing it, like with my patients, I always use like Dora the Explorer for some reason, maybe because I'm a mom. And I'm like, explore the pain as if you're Dora. And then like I start singing. I'm like, you just want to be silly and like laugh at yourself and just like inject playfulness and joy.
Daniela, we have to pause for a second because we are dealing with a Canadian audience as well. And are you guys familiar with Dora the Explorer up there?
Oh, yeah.
Oh, yeah.
Okay. All right. We always have to check our cultural references. They have some doozies up there that we've never heard of down here. So sometimes we have to check and see.
It's also a bit outdated. Like my kids don't watch Dora the Explorer anymore, but I did as a kid. So I don't know.
Yeah.
Yeah, it stems back to just a quick Daniela, so you know, we were talking about the tickle trunk. So we have it's like the Canadian Mr. Rogers is called Mr. Dress Up. You know, this tickle trunk. So Ryan had no idea what the heck we're talking about. So
I don't know what you're
kinda-
talking
yeah,
about.
kind of threw off the whole podcast there. So hence why we need to clarify these things for both audiences,
The
international audiences.
The tickle trunk is where you keep costumes that you could dress up in and have fun. And it's a lighthearted thing. But these guys just dropped tickle trunk on me. I'm like, what the hell is that? It was great.
I liked the when you mentioned the Hawkeye stuff, Daniela. I liked how there was that comparison. I think it was the same comparison of just being in the ocean and watching a school of fish instead. Like, so you're just you're floating in the ocean, and the ocean around you would be like the pain in your back, and you're just noticing the fish, which would be the pain, and you're kind of like, are they together? And oh, look at them move and look at them go around, and you're just, it's a curiosity and a calm curiosity versus that Hawkeye watching the prey and dart around, right? So it's just less intense is what the message was there. Don't be so intense when trying to think about your pain. It's just that easy noticeability of it. Yeah, I thought it's just, visuals help me, so I like that. Any metaphors that are used, and I know Brooke's a big fan of metaphors.
Love it.
It's just, and I think clients, it really clicks when they're able to visualize something. So I liked that Alan had that stuff throughout his book. I think that was really helpful.
Absolutely. And he really encourages all the clinicians at the Pain Psychology Center to use that, you know, to the point where I've actually created like a list of metaphors and a list of analogies, just in case you're like mid-somatic tracking exercise and you're at a loss for like a good metaphor. So yeah, I mean, it's really, really helpful. And it's good to also personalize it. Like once you get to know your clients and you build rapport with them, you can kind of like use the things that are personal to them, you know, like, you know, their cat, imagine your cat, or imagine your, whatever it is that makes them feel safe, right?
That's
That's
great.
good. So when you're doing those exercises though, like, do you get pushback from clients when you try to, those metaphors, analogies, and the lighthearted piece? Like, because I work with a lot of clients who experience chronic pain, have been in car accidents and workplace accidents, and it is a serious thing for them. So I feel that it's can be such a touchy thing, and the last thing you want to do is try to make light of something that's caused them so much pain in their lives, right? So how would you handle some of that pushback at that phase of your treatment?
That's a really good question. I mean, you kind of have to be careful and meet your patient, just like with all work, you got to meet them where they're at. And so I'm never going to jump into a first session with a client and like rip out my Dora the Explorer or tickle trunk or whatever you call it metaphor. Like I'm going to start out by, you know, gathering information, just like every clinician does in the beginning, and finding out what's going on. And first, I usually do the psychoeducation piece so that, you know, I don't usually deal with their, you know, right brain with this somatic tracking and the mindfulness exercises before they kind of buy in with the left brain stuff, like all that logical and, you know, just like buying into their diagnosis. So I think that's, you can't skip steps. Like you first need to get the buy-in that there is nothing wrong with their body, because like I said before, those three components, the second component is safety reappraisal. And you can't tell someone that they're safe if they think that there's something wrong with their body. So you first need to say, there is nothing wrong with your body, and you need to explain why, and you need to back it up with scientific studies. And so, within my first couple of sessions, I usually like bore all of my patients with all of my scientific studies and throw them all at them. But I think it's really helpful, especially with this group of people, they really are thorough. A lot of them are really smart, really type A, really perfectionistic. And so it's very helpful to come from that perspective first, get the buy-in, and then you can, work on these things.
Mhm. So when clients are coming to see you guys, are they mandated or are they going there by choice? Because I would think if you're going by choice or referral, but ultimately it's up to you, there would already be a little bit of openness or acceptance, knowing like they know what you do. So
Yes.
I would hope that they would lean into it a little bit. Is that what you find, or?
Yeah, so most of my patients are really open in the beginning, but others will push back anyways. And so I'll actually bring that up and be like, well, there is a reason you came to me, right? So, but then again, there are people that are referred by their parents. Sometimes I work with teenagers. So no, they're not mandated. There's definitely choice. This is private practice. So yeah, I mean, people are usually open, and we are kind of that last resort. They've tried everything and they're like, there's something else here, and then they'll come to us. So yeah.
And that reappraisal of safety, it's often a mantra, isn't it? Like, I am safe, sending messages of safety to your mind and body, right? Are there other techniques to help reappraise that sense of safety?
Yeah, I mean, again, the same with the word fear. Some patients don't like the word safe. They want to say something else like, this is temporary. This comes and goes. We can go back to the ocean metaphor and say this comes and goes like the waves of the ocean. So it's kind of also really collaborating with your patient to figure out what makes them feel safer, or what takes their brain off of, high alert or hawk mode.
Yeah, no, that's a good point. Yeah. So that's, of course, meeting with clients, it's different for everyone. You have to customize that to that sense of safety for them or their interests, right?
Absolutely.
A portion of the book talks about, so you've helped someone gain some awareness and mindfulness, assess their safety, add pockets of joy into their lives, and they realize they've got some freedom from the pain. But that's not all, right? Because the idea of like a relapse, or kind of let your guard down and it's come back again, and people can feel disappointed sometimes. Maybe they feel upset with themselves. Oh no, here I am back in the same place again. That's a big portion of the work, is kind of how you follow through beyond the initial treatment, isn't it?
Yeah. I mean, it's relapse is very common. Almost everyone has relapse. I mean, if you think about your own lives, we all have some form of pain, and of neuroplastic pain, as we call it. Think about when you're nervous before you give a speech, how you get butterflies in your stomach, or you get a headache when you're stressed, or Ryan, you get lower back pain. And do you notice that it correlates with your own anxiety, your own stress? And so in those moments that patients will relapse, it's remember the things that helped you get out of pain the first time. And also remember that pain is a danger signal, right? So pain is your alarm system. It's telling you that there's something wrong with your body, but also it could be telling you that you're not taking care of something else underneath the surface, right? It's not just your body, but maybe you're not taking enough breaks. Maybe you're overworking yourself. Maybe, there's too much stress and you're not taking care of yourself. And so pain is almost your alarm system to do that for yourself. And so a lot of times patients will get better and they'll be like, oh, okay, I can go right back to my regular life as usual, without taking care of themselves, without taking breaks, without, taking the time that they need, or whatever it is. And yes, of course they'll relapse, because they go right back to how they were acting before. And so it'll take some time for them to recognize, oh, wait, there's a way that I got out of pain, and I got to do those same things. And once I do those things, my alarm system will be turned off.
Excellent. Yes, there's a lot of, I'm sure, kind of a reassurance and trying to help people kind of remember the steps they took in the first place to get back to that pain-free state, huh?
Mm-hmm.
Sure.
How long does treatment usually last for? Like, I'm assuming it's subjective based on the individual, but like what would the progression of it be, or how many weeks or months or years does it take to help heal this neuroplastic pain?
For me, it's usually 8 to 12 sessions, and then they're completely cured, which is pretty amazing, being that most of these people have gone through so much injections, medications, surgeries, and then to kind of come for some talk therapy for 8 to 12 sessions, and then, you know, they're done. It's incredible, and it makes my job so much fun, you know, because I'm a very results driven type of person. I'm pretty type A, like many of my chronic pain patients. So this is like so fun for me to get someone and then to be able to say goodbye to them, you know, after 8 to 12 sessions.
So are you accepting referrals from Vancouver? Can we send some people down to you?
Absolutely.
Yeah, no, that's great. Yeah.
Mhm.
I don't know if you mentioned this before we started, but is there any trainings that you do outside of the clinicians who work at the pain reprocessing center? Like, is there, you know, for therapists like us who might want to be trained in something like this, are those things offered by Alan or his team?
Yeah, so the Pain Reprocessing Therapy Center, that is where we train all clinicians. The Pain
Okay.
Psychology Center is where all of us practice, you know,
Gotcha.
under Alan's clinic. So Pain Reprocessing Therapy Center is what Alan and I and co-founded this training center where we actually train other clinicians in PRT.
That's great.
Mhm.
What does that training look like, Daniela?
It is 3 hours of video material during the week, followed by live 3-hour training every Sunday for 4 weeks. So it's about, you know, and the lives are actually very exciting. They're very interactive. We have practice, we bring audio clips, we have breakout groups. So really helping people, you know, throughout the week, they're kind of listening to Alan and I and whoever else kind of like talking about Pain Reprocessing Therapy Center, going module by module, you know, through the steps of the treatment. And then on Sundays, it's kind of an opportunity for all the clinicians to practice whatever they've learned over the week. Mhm.
Great. It seems like this approach has really taken off. You know, I was looking at the reviews that some people have posted, and you know, these are heavy hitters like Aaron Beck and Gabor Mate and Andrew Weil. Andrew Weil gives really great hugs, by the way. But these are heavy hitters in our field who are really getting behind this, right? So it seems like people are accepting the ideas and trying to incorporate these ideas into their therapeutic approaches, eh?
Mm-hmm. Yeah, we were actually just published in JAMA Psychiatry for the study we did in Boulder, Colorado, on 100 patients who underwent PRT for 4 weeks, twice a week. There were 66% of them that were nearly pain-free, and almost all of them, I think it was like 90-something, something like 96 or 97% were like completely. I don't remember the exact numbers, and maybe it's because it's totally past my bedtime at this point, but I mean, staggering numbers. And what's even, you know, more exciting is that these numbers held up like over the next, you know, year. They still remained pain-free a year later.
So great.
That's amazing.
That's great. And there's actually fMRI like research to back this, right? So you're working with medical doctors in the medical field just to document these changes happening within the brain.
Yeah, we
Go ahead.
No, they partnered with Torwager, and so not only does it go off of reported pain decrease, but also their brains changed. And so this is really what's exciting in the medical community, not only in the psychological community, in the mental health field, but it's also in the medical field. People are getting really excited about it because, you know, we're actually changing brains. So that's what's really exciting.
Chris, I was going to say for our listeners who are average Joe listeners, can you tell them what an fMRI is?
A functional MRI. So I'm not a neuroscientist, so I'm not going to claim to be, but it's just when they, kind of take pictures of what's going on with the brain and see which parts of the brain light up. And so in chronic pain patients, certain parts of the brain light up, usually kind of having to do with memory. And so those places don't light up after treatment, going to show that they did actually recover. Is that helpful?
Yes.
Okay.
absolutely.
Yeah, thanks for that. Did you ask me to explain that, Brooke? Because I think
I
Danielle
did,
just
but
bailed me
Danielle
out.
did such a better job, so
You
that's.
did.
Oh no.
No, it was great. Thank you.
I like to put them on the spot sometimes.
It's one of those
so
gotcha
great.
questions. Like, oh
Wait,
no,
Chris,
Here's a
can you explain
fancy-
it?
I know it's a very expensive machine,
Hmm.
and it's exactly what Danielle explained.
Like,
To-
I was getting really mad at Brooke for putting me on the spot. I'm like, how could you do this, Brooke?
That
No.
was for me. Yeah.
I actually know a little bit about this if you want to hear. It's so an MRI, magnetic resonance imaging is a snapshot, but functional magnetic resonance imaging is like a video, like you see what's actually happening over time. And so that's how you can tell like what's actually going on moment to moment in the brain. And that's how you get a much better picture of what's happening. So that's cool stuff. So is there anything next? Is there a next frontier that that the research or even your clinic is working towards, Daniela?
We have a lot of stuff that we're working toward right now. But, like I said from the beginning, our mission is to really change the way that chronic pain is treated worldwide. And so we want to make it more accessible to everyone. Pain Psychology Center is just private practice. And so, like Brooke was saying before, that there are so many people in different cultural places that are just more, susceptible to these things. And we can't really reach them because we're private practice. And so we're expensive. And so we want to make this more accessible to everyone. And I can't go too deeply into all of that, but we have some exciting stuff coming to fulfill this mission. And we're really, really excited.
That's great. For our listeners who might be experiencing chronic pain themselves, besides reading the book, is there something else they can do to get some extra support? Any other resources out there? I thought I came across an online, a podcast.
There's a podcast called Tell Me About Your Pain.
Okay.
There's also Curable. Curable is great. That's an app that is pretty accessible. So those are good.
Good. Fantastic. I think one major message, I think the biggest message from today is one of hope. My goodness. A lot of folks out there experiencing chronic pain and feeling very trapped in that pain. So pretty exciting work that you're doing.
Mm-hmm. Yeah, kind of hope and empowerment. And I feel like empowerment is really the antidote to fear, and fear is really at the root of pain. So I hope that everyone feels more hopeful and empowered that they can, beat this. I've seen it hundreds of times, so I feel really confident in the treatment.
Mhm.
Well
Amazing.
put.
That's great. Daniela, where can people find you online or find your clinic and trainings, that sort of thing?
Well, you can find the training center at painreprocessingtherapycenter.com, and that's for therapists who would like to be trained in PRT. As far as getting treatment, it's painpsychologycenter.com.
Excellent. And you guys are located here in Los Angeles, right?
Yes, but we work mostly virtually, so we can treat Canadians.
There you go.
Oh,
There we go. Well, this has been a pleasure to speak with you and enlightening for all of us. And it was great to read the book, but even better to hear from someone who actually is doing the work currently, even past your bedtime. So thank you so much, Daniela.
Thanks so much for having me.
That's great. Well, thank you to Daniela Deutsch. Appreciate your time. And we'll just sign off for now. So that's it for us. Everyone can like and subscribe on Apple, Google, Podbean, Audible, Stitcher, or YouTube. Send your questions to info@mentalhealthbootcamp.com. Visit us on Facebook or Instagram. Tell a friend or two. Tell someone who has chronic pain to write on in or visit Daniela. And we'll say goodnight for now. Good night, everybody.
everybody.
Night.
Toodles.
Bye.
Bye.